A very good morning once again, and I welcome you all to the second instruction course for the day. And before we start with the instruction course, we have with us Dr. Shaukat Ara Shakur Mili, ma'am, who I'd like to invite her for her keynote address. But before that, let me just introduce ma'am. Dr. Mili is currently the professor and head of Department of Community Ophthalmology at National Institute of Ophthalmology and Hospital, Dhaka, Bangladesh. She's also working for oculoplasty, orbit, and ocular oncology services at the institute. And Dr. Shakur did her MBBS from Chittagong Medical College in 1990 and went to UK in a Commonwealth scholarship and did her MSc Community Eye Health from ICEH-UCL in 2002. She completed her MS in ophthalmology in 2007 and did her fellowship in oculoplasty and ocular oncology under Dr. Santosh Hanavar. Ma'am's also trained in Nepal and Australia. Her special interest area is retinoblastoma, and she's established the first comprehensive center for retinoblastoma in the country. She's the recipient of Firoza Zalil Award by OSP in 2003, Australian Leadership Awards Fellowship ALAF in 2009, ACOIN Matin Memorial Oration Award in 2009. She's interested in research and has many publications. Dr. Shakur is actively involved in activities of Ophthalmic Society of Bangladesh. She was also elected treasurer of OSP for 2 terms. And she's the current vice president of Bangladesh Oculoplastic Surgeons Society. So with that introduction, it's my privilege and honor to welcome Dr. Mili for her keynote address on ocular oncology cases, my experience. Dr. Mili.
Good morning, and thank you for the nice introduction. And I thank AIOC AIOS for inviting me to give lecture here in front of you. Thank you. So I'll be sharing my ocular oncology cases, my experience. So this is a story about a 1-day-old boy who presented to us with proptosis, and with huge proptosis, and you can, do you have marker? Pointer? So, okay. And you can see in the CT scan how big the growth was. And then we did, on the 16th day of the birth, we had to do the surgery, and we had no other option other than to excise the whole of the eyeball. And we did the histopathology, and it was retinal artery hemangioblastoma. But then we sent the specimen to slice to the National Reporting Center for Ophthalmic Pathology, Hyderabad, and they confirmed the diagnosis with immunohistochemistry hemangioblastoma. But our diagnosis was, initially we thought it is a teratoma, and hemangioblastoma came as a diagnosis. We did all other investigation, including the ultrasonogram of the whole abdomen of the baby, and it was normal. We screened the parents also, normal findings, nothing abnormal was there. So for these patients, hemangioblastoma in a child, we have to do screening of the parents and the child, and to exclude any other congenital abnormalities. And this is the boy after reconstruction. So the message is here. So it is not only the ocular oncologists, we have to just remove the tumor, but we have to look at the aesthetic part of the patient also. So after 5 years age, the boy is like this now, with serial surgeries and with serial increasing size of conformer was placed. And finally, we did the secondary orbital implant, and with the prosthesis, now he looks like this. So this is a job we did. This is a case about a boy, a man, I must say. He was a 22-year-old man, and he came to us with a large pigmented lesion in his left lid, upper and lower lid. And it had birth blemish and which was then gradually increasing in size. So it was an embarrassment for him. The diagnosis was, you can see the nevus, kissing nevus. And here we did the en bloc dissection of the excision of the lesion and then skin graft. After this is the outcome. So, but the interesting thing is we got the histological report, intradermal nevus. We went through the journals, different reports, and we found that most of the reported kissing nevus were junctional. But in our cases, also in our series, we found the intradermal nevus. In this case, we are following the case because these large nevus, sometimes it turns into malignancy, and we have to follow them. This case is a man of 27-year-old presented to us with huge proptosis. And it was like kind of neglected when he presented to us. He didn't present earlier, so it was like a very neglected case. And we did the CT scan. You can see the lacrimal gland swelling. But the interesting thing is, it was so big. It entered almost in the cavernous sinus. So there was intracranial extension and going up to the cavernous sinus. So this case, we have to consult with neurosurgeon. We referred this case to the neurosurgery department of Institute of Neuroscience, and in conjunction with the neurosurgeons, we did the surgery, and after surgery, this is gone. But we couldn't, histologically it was adenocystic carcinoma of the lacrimal gland, and the patient is under our follow-up, but we couldn't save the eye, so it had ptosis, and we have to do the evisceration later on. But the disease he was disease-free. So these are the cases. We have dilemmas, different type of cases, and we have to work with other specialties. This is a case of retinoblastoma. But we get very young patients usually. But this patient presented to us at 11 years old, and it's a bit older patient. He had retinoblastoma, but vision was 6/9, unaided. Group D retinoblastoma, this is the tumor with vitreous seeds. We started first high-dose chemo as a protocol, but the tumor was gone with one cycle chemo, tumor was gone, but the seeds were there. These are we continued standard chemo and periocular injection of carboplatin and then topotecan. Vitreous seeds were reducing, but not going completely. Then we gave intravitreal topotecan. With topotecan, the vitreous seed responded well, but not gone completely. So at that time, we had in Bangladesh, we had our one Australian ocular oncologist, and we discussed the case with him. And he proposed enucleation, but with visual acuity 6/9. So though it is a cancer patient, retinoblastoma, we are also thinking about the visual rehabilitation. As the patient had 6/9 vision, I thought, no, it is not, I can't agree with enucleation. So what next? As I have networking with Center for Sites, Dr. Santosh Honavar, I referred this case to Dr. Santosh Honavar. And he was then treated with intravitreal melphalan and topotecan, and he did well. But he developed in cataract in left eye. So when he came back to me again with tumor regressed, he had cataract. So we had to do our pediatric fellow, our colleague, he did the phaco with PCIOL, and the patient is doing well. He has vision 6/6. So in this case, you can see this, the vitreous, during this time, we send the patient to Center for Sight and tumor-free case. The patient is doing very well, but the thing is, we have networking with international networking and also pediatric ophthalmology. So like this, we have to treat a case, not only just I will do. No, we have to involve others also, other subspecialties, other centers for the benefit of the patient. And this is my case number 5. It is also an interesting case. So I'm showing some interesting cases and some normal cases which day to day we deal with. So this case was a very old patient, 85-year-old patient. He came with huge left eyelid, upper lid growth. And the eyeball was not recognizable. Lymph node, there was no lymph node enlargement, no CNS involvement. And first we did, for any diagnosis, we do incisional biopsy, and we did the incisional biopsy. It came sarcomatoid carcinoma of the lid. It is a biphasic tumor, and very uncommon type of tumor. So CT scan, you can see this in the CT scan, how big the lesion is. And here also the involvement of the extraocular muscle and lacrimal gland. So we did the operation, we had no other option rather than doing, this was the case. Time up. And this is the post-exenteration. Oh, I can continue. Okay. So this is and this is a case of lymphangioma. And we treated it with bleomycin. This is it. After one cycle of bleomycin. Capillary hemangioma, I can show you with squamous cell carcinoma, and after excision with 4 millimeter free margin, alcohol epithelectomy, cryo and amniotic membrane. This is how we treat and the outcome. The patients are doing well. But we get this type of cases with squamous cell carcinoma with orbital extension, where exenteration is the treatment. Shall I stop here? Okay, thank you. Thank you. I had many cases, but okay, thank you.
Thank you, Dr. Meel, and I think we've seen a wide spectrum of oncology cases in your talk. And now we go on with our instruction course. So welcome once again. And yeah, this one. So yes, so the instruction course is titled A Quick Appraisal of Recent Trends for Common Ophthalmic Tumors. And I am privileged and very honored to have a team of very experienced oculoplastic and tumor surgeons with me today, some of whom have been my teachers and very well renowned. We have Professor M.S. Bajaj, who's head of oculoplasty and ocular oncology at RP Center AIMS. Professor Neelam Pushkar, who's professor oculoplasty and ocular oncology again at RPC. Dr. Maya Hada, also a pass out of RP Center, now working as an assistant professor in SMS Medical College, Jaipur, Rajasthan. We have Dr. Seema Das, who is head of oculoplasty and ocular oncology, Shroff Charity Eye Hospital, Daryaganj, New Delhi. And Professor Seema Kashyap, ma'am, she's a professor, Department of Ocular Pathology at RP Center. And Dr. Niweti Lomi, Assistant Professor, Ocular Oncology at RP Center AIMS. So that's our team. And the idea of the instruction course today here, as the title says, is a quick appraisal of recent trends for common ophthalmic tumors. So what we want here today is that we help you understand the recent management trends and what's best way to treat some of the common tumors that you may come across according to the recent trends. And that is what we are going to do. And without delay, I would go on to the and shall I first invite my co-instructors onto the dais. Dr. Neelam, Dr. Seema Kashyap, Dr. Niveti Romi, Dr. Maya Hada, Dr. Seema Das, kindly join me on the dais, please. Thank you. Dr. Bajaj will shortly be joining us. I think we'll start with the first talk, otherwise we'll run short on time. And the first talk is on ocular surface squamous neoplasias. And the common question that many of us have and which many of us ask is whether to excise or use topical therapy and what's the best for a tumor that presents to you. So I have no financial disclosures to make, and yeah. So I realize that you do something better if you know why you're doing it. So if you know why you would like to hear to this talk, maybe you can carry home the message better, and that's why I thought this should be the first slide. So ocular surface squamous neoplasia is the most common ocular surface malignancy, with an incidence that's been reported of around 1 in 1 lakh population. But India is in a zone which has high solar radiation exposure. So if you are practicing in India, or for that matter, any other area close to the tropic, then you are more than likely to come across a lot of these patients with ocular surface squamous neoplasia. And it is then that one would wonder, what is the best way to treat these patients? So before I go on and answer that question in today's scenario, I would like you to understand that ocular surface squamous neoplasia, despite being a cancer, is not one of the cancers where you think of fertility or death. It is a tumor which is characterized by high morbidity, and the morbidity is related to recurrence. So you could see recurrences in as high as 56% of cases, which could go on and cause intraocular invasion, or maybe an orbital invasion requiring exenteration. So much so that it is now one of the most common causes of exenteration. Metastasis, if you see, it occurs in less than 8% of cases, and death would be in less than 5% cases. So mortality remains the main cause of concern, which could be in terms of corneal opacity, in terms of intraocular extension requiring enucleation, corneal melting, or even exenteration, which is extremely disfiguring. So what are the treatment options? Of course, you want to treat the patient with something that would reduce the recurrence rate in these patients, thus reducing the morbidity. So you could do surgical excision, which still remains the standard of care, and then you have topical treatment. So we know that surgical technique is quite well defined for ocular surface squamous tumors. It has to be a wide local excision with no touch technique, because we don't want to touch the tumor. If you touch the tumor and manipulate it, it will cause seeding of the surrounding conjunctiva, bringing about recurrences. Also, you would want to do an alcohol-assisted epithelialectomy of the involved corneal epithelium and a reverse double freeze-thaw cryo of the conjunctival margins. That is that. But surgical excision can have high recurrences, especially if the surgical margins are positive. And also, you may not be very comfortable doing surgery in large or extensive tumors. And that brings us to why topical treatment is so attractive and has become so popular. So though surgery remains the gold standard of treatment, there are advantages of topical treatment, including painless. It's painless and minimally invasive, treats the entire ocular surface, even the hidden or missed areas. And surgery is, of course, difficult in cases like this, or maybe even this, where you cannot see the margins of the tumor. But that doesn't mean you go in and use topical treatment in all the cases. So you must know where not to use topical therapy. So you do not use topical therapy if you have invasion of the ocular coats. How to assess that? You could do a clinical mobility, or you could do UBM or OCT. So this is the UBM of a case where there's no scleral invasion. This is another case, and you can see scleral thinning and possibly invasion. Another one with corneal stromal invasion. But then there are also other high-risk features you must keep in mind. So if there's history of previous surgery, morphology which is nodulo-ulcerative or endophytic, or a mucoepidermoid histology, go in for surgery and not topical therapy. So when should you use topical treatment? When surgery is likely to have significant side effects, larger tumors, like this, or maybe like this, but they should not have ocular coat invasion, where patient has a smaller tumor but is unfit for surgery, or as adjuvant treatment where margins are positive or unassessed. What are the choices? You have chemotherapy and immunotherapy. So chemotherapy is what is still being very popularly used in our country and maybe the world over as well. That's because it is cheaper, it has shorter duration of action, and it can be stored at room temperature. But most importantly, what is making immunotherapy more popular? Greater side effects of chemotherapy. Mitomycin C is the most common agent that's used, and it has side effects. It can cause limbal stem cell deficiency. It can cause lacrimal punctal stenosis. This patient we treated with MMC, and after that, he developed a stenosis and watering. And if the patient uses it without you telling him to do so for years on, you can have scleral corneal melt. So now, immunotherapy is actually replacing Mitomycin C as the first line. What is it? It's a cytokine, interferon alpha-2b that is used. It comes as an injection, needs to be reconstituted to drops. You can use it as 1 million international units per ml or as subconjunctival injections. We use it as first line at our center, and many centers do in the world. Now, how to decide between topical versus perilesional therapy? So what you need to remember is, if you want to give topical interferon, you need to have cold storage, and perilesional interferons produce systemic flu-like side effects. So if you have a doubtful compliance issue, or the cold storage is problematic, or you're aiming at a faster response, it's better to use perilesional therapy. If the compliance is assured, cold storage is not an issue, and perilesional is not feasible, like in this case, topical is a better choice. This is a short video on the technique. I think I'll skip that, otherwise I'll run out of time. If I have time, I'll show it in the end. The protocol that we follow for eye drops is, you start the eye drops and reassess after 6 weeks. If there's a decrease in size, continue, reassess every 4 weeks till it regresses, or till complete regression, and continue for 1 month. For injections, we reassess after 2 injections, and injections are given at 2 weekly intervals. And thereafter, you reassess after 2 weeks and continue till complete regression. It is important to remember that you have to give a maintenance therapy of 1 to 2 months of topical treatment after complete regression of tumors. This has been our experience with use of interferons. I will just run through the slides. We have seen extensive tumors just melt away with this drug when it works, and even the ones which are very, very large and diffuse involving the limbus. But then there are other smaller ones which have not responded, but they do, then as second line we use MMC, and then they disappear too. Some of them do not respond, like in this case, where they get immunoreduced, and thereafter we have excised and managed to save the eye in this case. We did a study on the cases that we have treated, and we found that almost 66% of our cases had complete regression that were treated with conservative treatment, and 92% showed some response. So to conclude, upfront surgery should be done for smaller tumors. There are tumors less than 3 clock hours or limbal involvement less than 5 millimeters, tumors with scleral or corneal stromal invasion. Topical treatment should be restricted to larger tumors without scleral or corneal stromal invasion with immunotherapy as the first line. Whether perilesional or topical has to be decided on case-to-case basis. MMC can be used as second line, and of course it can be used as adjuvant treatment after surgical excision. Thank you so much. I think we'll take the questions at the end of the session, and now I invite, since I think we'll go on to the third speaker first. I invite Professor Neelam Pushkar, ma'am. Her talk is on a very interesting topic and very valid, sentinel lymph node biopsy. Where is it relevant?
Thank you, Dr. Rachna. Good morning, everyone. I'll be talking about sentinel lymph node biopsy in eyelid malignancy. Sentinel lymph node, we know, is the first draining lymph node of a lymph basin, which can be more than one in number. We assume that there is orderly and predictable pattern of lymphatic spread along the conventional lymph basin. If you see the sketch diagram below, we assume that everything, the part of the lid which is above the red line, should drain into the preauricular and parotid group of lymph nodes, and below the line should drain to the submandibular lymph node. But now we have ample literature saying that irrespective of the site in the eyelid, the commonest sentinel lymph node we find in the preauricular and parotid group of lymph nodes. So why sentinel lymph node biopsy in these patients? We know that except basal cell carcinoma, most of the other lid malignancies, they have regional lymphatic spread. And we see in squamous cell carcinoma around 10 to 30%, in sebaceous cell carcinoma around 10 to 15%, eyelid melanomas 30%, and highest we see in conjunctival melanoma, which is around 20 to 40%. So sentinel lymph node biopsy is basically done in patients where clinically we don't palpate any lymph node, or on imaging there is no evidence of any lymph node spread. And we assume that the sentinel lymph node will harbor the malignant cells, being the first lymph node to encounter the malignant cell spread. So basically, when we do the sentinel lymph node biopsy, we identify in the subclinical stage the lymphatic spread, and we can timely do the management and do a proper staging. And studies have shown that survival is definitely better in the sentinel lymph node positive patients when you compare with patients coming with gross lymph node spread. So what are the indications? There are very few studies and mostly the studies are on melanomas. So if you see here, these criteria, if you see, they are all histopathological features. So basically when a patient with melanoma, whether it's a conjunctival or eyelid, comes to you, you have to excise the tumor and wait for the pathology report to come. And these are the features you should remember. These are high-risk features where we expect that they can be, lymphatic spread. So for eyelid skin melanoma, the criteria include Breslow thickness more than 1 mm, Clark's level 4 or higher, which means invasion of the reticular dermis or the subcutaneous region, or if the thickness is indeterminable or more than one mitotic figures seen per high power field, or patients with surface ulceration. For conjunctival melanoma, the indications are Breslow thickness more than 1 mm, indeterminable thickness, large areas of diffuse pigmentation, and surface ulceration. For sebaceous and squamous, there are very few studies on sentinel lymph node biopsy. I would say 1 or 2, which I could find. So here, according to the size of the tumor, clinical size, when we stage the tumor, if it is more than equal to 2B as per the 8th edition of AJCC, then that is the group of patient where we see more lymphatic spread and we can consider sentinel lymph node biopsy. For squamous cell carcinoma, the indication I could found was more than 2 centimeter in diameter, recurrent lesion, or patients with perineural invasion. This is the AJCC 8th edition which we follow at our center for staging the tumor. And any tumor which is more than equal to stage T to B, where the tumor is between 10 to 20 mm size or bigger than that, or where there is invasion of the tarsal plate or the eyelid margin. These patients, we ideally, if the facility is there, we should consider sentinel lymph node biopsy. For conjunctival melanoma, also we have AJCC staging, 8th edition, which we follow at our center. This basically divides the tumor stage as clinical and pathological. And clinical, depending on whether it is bulbar or non-bulbar. So the non-bulbar has a higher risk of spread. So who does the sentinel lymph node biopsy? It is not done by the oculoplasty surgeon. It is done by the oncology surgeon. who's familiar with the procedure of sentinel lymph node biopsy. This is done in collaboration with the nuclear medicine department, and of course, pathologists will let us know the final diagnosis. So what are the ways we can find the sentinel lymph node? Blue dye technique is a technique where we inject either 1% isosulfan blue or methylene blue dye. Preferred is isosulfan because we see more allergic reaction with the methylene blue dye. Around 1 ml is injected, around 3 to 4 spots are given around the tumor. For the lid tumor, we give intradermal injections, and for the conjunctival lesion, we give subconjunctival injections. Then within say 5 to 10 minutes, we have to give the incision and we have to visualize where the stained lymph nodes are. Those lymph nodes are considered sentinel lymph nodes and those are taken out. The reported side effects are bluish discoloration of injected area and urine, which lasts for 24 to 48 hours. Allergic reaction, very rare. Anaphylaxis also you can come across. And the main disadvantage or limitation, I would say, is the low sentinel lymph node identification rate with only blue dye technique. I'll come to the other technique also. This is one patient where you can see the stained lymph node, and this lymph node was taken out, and this was positive on histopathology. The other technique is radiotracer technique, where in the similar fashion, 3 to 4 injections are given of radioactive technetium-99. And again, after say 5 to 10 minutes, preoperatively we can detect the hot lymph node by doing hybrid SPECT CT or lymphoscintigraphy. I'll come to this. Intraoperatively, you can detect the hot node by using handheld gamma probe. And you should have a portable scintillation counter machine with this. I'll show you this. And then once we detect the hot node, we have to give the cut in that particular area. The cut is usually small in size. And we take out the lymph node which has got the highest radioactivity. Then the ex vivo count is checked. And then all the lymph nodes which are more than 10% of that radioactivity, we consider sentinel lymph node and we take them out. On an average, most of the studies will see that 2 to 3 lymph nodes are taken out, so it's not a very invasive procedure as such, but still it has some problems, and especially the high cost, expertise, and radiation exposure. Sorry. So this is here, the picture above you see, this is the hybrid SPECT CT. It is basically, it has got dual camera, it has got a CT camera and a gamma scanner, and this is how you get the image. The lowest one you see only the radioactive hot node as a spot. Then in the middle one you can see it's like a CT film, and then the above one is the overlapped image. So the advantage of SPECT CT is that you can see the hot node in relation with the anatomy all around. So it becomes very easy for the surgeon to locate the incision and to do the dissection. And below you can see that is how the conventional lymphoscintigraphy, you can see the hot area, which is basically the primary lymph node, primary area where we injected the dye. You can see it's very hot. And over here you can see these are the two radioactive hot nodes. So if you compare with the above picture, you can't see the surrounding anatomy and the exact location of the sentinel lymph node. So that is the disadvantage of conventional lymphoscintigraphy. Intraoperatively, once you give the injection, you can use the gamma probe. This is the gamma probe, and the hottest node has been taken out, and you keep it over the probe. Then you see what is the radioactive count over here. This is the, the machine which will tell you the radioactive count. Then 10% and above of all the lymph nodes which have that particular count, you take them out. And this is the cut you see. It's a very small cut. Depending on where the hot lymph node is, you give the cut. So the added advantage of this procedure is that you know where to place the incision, which you cannot do in blue dye technique alone. So that's why most of the surgeons, they combine the two techniques. The blue dye will help in visualization of the lymph node easily, and the radiotracer technique will help in preoperatively and intraoperatively planning of the incision. And the dual dye technique, it has 100% identification rates of sentinel lymph node. Just 2 minutes, please. So if we see the reports on sentinel lymph node biopsy, there are hardly any, and mostly they are from one center. And we have published 2 reports, which are the only reports from our country. So this is little bit briefly about the study which we started in 2010. We took patients more than 1/3 of the lid involvement except BCC. We could enroll around 38 patients. SPECT CT we could do in 30 patients, and radio tracer we could do in 35, blue dye in 37, and dual dye technique was used in 34 patients. The procedure took on an average 30 minutes. And so these were the patients, those who were biopsy-proven lid malignancy. So once the SPECT CT was done, patient was shifted to OT on the same day, and using the gamma probe, we looked for the radioactivity. Where we see the highest, we give the cut, and we take out all the hot and the blue lymph nodes. Send for histopathology. If it is positive, go ahead with modified radical neck dissection with radiotherapy. That completes your treatment. So in a way, we are timely treating these patients, and then we go ahead with the removal of the lid tumor, whether we can excise or exenterate, that depends on the stage of the tumor. So this is the same study I was talking about. So in this particular study, we found that out of 38 patients, 2 patients, they had sentinel lymph node positive. Both patients underwent exenteration, so they were basically advanced stage patients. The false negativity was seen only in 1 patient, so that reduced to almost 2.7%. And in our study, overall 14 patients had to undergo exenteration. 2 patients, they died because of this systemic metastasis, out of which 1 patient was the one where false negative lymph node was reported. This is just to show the island of, the tumor within the lymph node. This was a case of sebaceous cell carcinoma. And if you review the literature, you will see that in most of these studies, the sentinel lymph node positivity is around, it varies between, say 5% to 20%. The latest review is published in 2017, where the authors, they found that the sentinel lymph node positivity is seen in around 20% patient, and false negative reports are very rare. And if you see the complications, they are very few, and most of them, they are transient. So take-home message is that regional lymph node workup is very important. Even if you don't have this facility of sentinel lymph node biopsy, please go ahead with some kind of imaging for the lymph node. We prefer ultrasound, so you can advise regular basis ultrasound, maybe say 6 monthly, to look for preauricular, parotid, and neck lymph nodes. So that is very important. Sentinel lymph node biopsy is a feasible and safe procedure if it is available. And usefulness, or we can say that the indication, what are the patients where really this procedure is justified, that those indications we are, it's still investigational and still evolving. Thank you.
Thank you, ma'am, for that very informative talk on sentinel lymph node biopsy. We'll take questions at the end of the instruction course. May I now invite Professor Mandeep Singh Bajaj for his talk on sclerotherapy in periocular no or low flow vascular malformations, when and how.
Very good morning, ladies and gentlemen. So we've negotiated our way through the dust in the parking lots and everything, so we've come a long way here coming to this hall. So let's make the best of our time. So I'll be discussing this very challenging topic, which is a challenge challenge for our treatment, how to go about it. And basically these venolymphatic malformations there's a spectrum. They can be either purely venous or purely lymphatic, but in actual clinical setups, you do not see most of the pure venous or the pure lymphatic ones, but usually they are in between, the venolymphatic combination. But the pure venous ones, these are some of the characteristics of those slowly growing, well circumscribed. And the lymphatic malformations, again, are a congenital slow flow vascular abnormality resulting from abnormal development of the lymphatic system. And these are the incidence and the sex ratio. And usually they are diagnosed at birth, and most of them affect the head and neck region. And within that, our purview is for the orbital lesions and the periocular lesions, where we see them in our specialty. And they can cause occasional complications in between, like sudden, intralesional bleeds, infection, swelling, and causing sudden blepharoptosis and proptosis, and leading to some urgent situations where you need to manage them. And so they are basically classified into macro and mixed variety, depending on the cyst size in between. The macro ones have obviously very large cystic cavities, and the micro ones on imaging are having a small cyst which are barely visualized on imaging, whereas the mixed variety has a part of both. So this is a MRI image of a macrocystic one, where you can see some fluid levels. And I put the other extreme, which is the microcystic variety, where it's just a large diffuse mass where you cannot really visualize the cyst there. So these are very small cysts, and it's almost an organized solid mass there. So presently, what are the treatment options that we have? Like for many years, we have been doing debulking surgery for these lesions with variable success, because as you know, the main problem is that they are very diffuse, and they are not a circumscribed lesion. So they are involving the entire orbit and even engulfing the optic nerve. So at best, you can debulk some part of the lesion without compromising the lesion. And steroids we have been using for acute exacerbations, and when there is a bleed or there is a sudden increase in the lesion due to some episode which leads to increase in the lymphatic glands and the tissues. And the various sclerosing agents have been used over time historically, which are listed here. I think you're all familiar with most of them. And now picibellin is one of the supposedly the best agents, but the problem is that it's expensive and it's not available. You have to import it. Whereas bleomycin and its derivative vingyangmycin we found them equally effective. They are cheap, they are easily available here, and they are very good for our patients. So for in an Indian scenario, we found bleomycin to be a good substitute for the other agents. And recently, of course, sildenafil and then cyanoacrylate glue for the superficial lesions and fibrin glue for the deeper lesions have also been tried. So why did we choose bleomycin? Because as I told you earlier, these lesions pose a therapeutic challenge, and the surgical management is fraught with danger, and it may not be so effective, and other sclerosing agents may have some serious complications, whereas the most common complication of bleomycin in the head and neck region is pulmonary fibrosis, but it occurs at doses which are even maybe 20 times more than the ones that we require for the orbital lesions. So pulmonary fibrosis is not an issue as far as our lesions are concerned. And then it's a very non-invasive procedure, and I'll just show you the outcomes which in our series of patients, right? So we'll just go on to the mechanism of action Various things have been described, but basically it causes inflammatory reaction and fibrosis, or thrombus formation, or oxidative damage. As you know, bleomycin is an anti-cancer agent, so one of the mechanisms is through that, and the other ones are due to the inflammatory reactions that it causes. Of course, apoptosis is also an important mechanism, and the list goes on and on. You can, just for academic purposes. So now people have described various doses, various permutation combinations. Some people do it according to the per kg body weight, but we found that the safest is to give 1 international unit per ml of saline mixed with lignocaine, and that is a safe dose and it is quite effective. And we give the injection either with a 26 gauge needle or a 23 gauge needle, depending on how much deep you want to go. And in the macrocystic variety, after we aspirate the contents, without withdrawing the needle, we can inject a volume equal to what was aspirated. And we have also tried this in cavernous lymphangiomas, low flow venous malformations, and in the microcystic and mixed varieties. You can inject a volume equal to the largest pocket of the lesion, or the one that is measured, which is with MRI or USG, subject to a maximum of 5 ml, because we've seen that if you inject more than 5 ml, then it can cause pressure symptoms inside the orbit, and it may be causing its own problems with compressive neuropathy. So we did send the samples for cytopathological examination, but usually it came out as a blood only. And then you can give serial injections at an interval of 4 to 6 weeks, up to a maximum of, say, 3 to 5 injections, and it does lead to a progressive reduction in the size of the lesion, depending on the response that you got with the first or the second injection. So this is a short video we are doing it in a real-time ultrasound B-scan monitoring, after identifying the pocket on that and corroborating it, of course, with the MRI findings. We go in that quadrant, and then with a larger syringe which can cause more negative pressure, we go and try to aspirate the lesion. You can move the syringe a little forward and backwards to find the exact largest point where you can aspirate, and then without withdrawing the needle, you can inject bleomycin 1 international unit per ml through the same needle into that exactly the same point from where you aspirated the contents. And then after that, pressure for about a couple of minutes, and then followed by a short course of systemic steroids, and local NSAIDs is helpful. So usually pre-op, we do a UBM, a USG, and preferably an MRI for the patients. Sometimes CT may be more useful for volumetry, but that is, MRI is also equally good, and one should prefer doing an MRI. And we graded the response from an excellent to a poor response according to this classification. And now I'll just show you the cases where it was done. This was a case which had a massive kind of a swelling and a proptosis, and this is the post-injection finding. These are the MRI pictures where you can see the very clear fluid levels in this. And now after the injection, you can see how much the lesion has regressed. Another case which had a component in the orbit as well as an anterior component in the lid. And you can see after these are not only after one injection, some are, multiple injections also. So we are not going into that right now, but usually we gave about the maximum of 5 injections. So you can see both the components have significantly regressed. And these are the imaging findings of this case, showing both the orbital and the anterior component. And below the 3 pictures, you can see the post-injection imaging findings. Okay, so I think we'll just take last few slides. Can you just take off this? Yeah. Okay. Right. So another patient showing both orbital and lid findings, the post-injection findings. The MRI, you can see a very dramatic reduction in the lesion on MRI. Another case, she had an orbital as well as a component on the forehead. So this is what we did for the orbital component, and then she had serial injections for the forehead component, which also reduced almost to normal. So the point is that not only can you do the orbital one, you can do the eyelid and the, lesional component also. But the only precaution that you should take is that you should give a deep intralesional injection, because if you give it very superficially, sometimes it can cause some excoriation of the skin. So go deep into the lesion. Again, another case, this is the same case which I showed you the picture. You can see it almost regressed to normal. Another case from Northeast, he had a significant proptosis and an orbital component. And you can see his pictures here that it's significantly reduced. And this was our first case actually, which we did. She had a very large orbital lesion, and now she's absolutely symptom-free. And absolutely all these patients had no disturbance in vision. All the patients had perfect vision even after the injections. This is that case imaging findings which I just showed you, case 6. And so I think we are running short of time, so we'll just run through these last 3-4 patients. Another patient showing that you can see that such a large lesion and regressing to just few minimal pockets later on, and a significant reduction in proptosis. This patient had a cyst in the lower eyelid, in the preseptal cyst in the lower eyelid, so it's a little different from the previous cases. And you can see there are fluid levels there, and which have now totally resolved. So there are few complications. You can have conjunctival chemosis, which is transient. Like I told you, if you give an injection superficially, or if it extravasates into the superficial compartment, it can cause this thing, little skin discoloration, and subconjunctival hemorrhage, which are all manageable. So just to conclude, it's a very safe and effective agent for these lesions, and it can be considered as a first-line management. Rather, it should be considered. And repeat injections can be given, as I already discussed. And it's a very minimally invasive procedure which avoids the need of major surgical interventions, which could be ineffective and could lead to sight-threatening complications. Thank you for your attention.
Thank you, sir, for that wonderful overview for this, I think, most gratifying non-surgical intervention for one of the most surgically challenging entities in pediatric oncology. I'm sure many of us have dealt with lymphangiomas and how frustrating sometimes the surgeries can be. And I'm sure after the talk, everyone would want to try intralesional sclerotherapy in these cases rather than surgery. So with that, we go on to our next speaker, Dr. Seema Das, and she would be talking about what's new in eyelid malignancies, what you must know. Next presentation. If anyone has any questions from the talks till now, yeah, we are here to answer any queries.
Thank you, Dr. Rachna, for including me in this IC. So I'll be talking about eyelid tumors and what we must know. So eyelid tumors has traditionally been the forte of not only the oncology people, but also comprehensive ophthalmologists, and we all has been managing these tumors. Surgical excision remains the mainstay of treatment. My purpose of the talk will be just to highlight like couple of few oncological principles basically which we need to follow while managing these tumors, and also to highlight a few new advances which probably is going to make the management of these tumors more of non-surgical. So I'll try to cover these 4 main tumors if the time permits. Starting with the sebaceous, these are the type of tumors which we most commonly see in our part of the world, and this is how they commonly present to us. So whenever we see a case of sebaceous gland carcinoma, as highlighted by Dr. Neelam also, it's important to classify these tumors. And the staging system which is most commonly followed is the TNM staging system. So currently we are following the AGCC 8th edition of the staging system. However, there has been a few differences between the two. The 7th edition, which was used to be followed earlier, and the 8th edition, which is currently being followed. It's important to know it because if we have to compare our results with the earlier literature, it's important to know what is the difference between the staging in the, especially the T category in the two systems. So essentially what has been done in the 8th edition is that the dimension of the tumor, which is included in the T1 and T2, has been little more than what it was earlier in the 7th edition. Means that you are downstaging the tumors at T1, and while in T3 and T4, some of the tumors which are earlier included in the basket of T3 has now moved into T4. So you're upstaging the tumors at that. So what essentially it means that 8th edition seems to predict the local recurrence and the lymph node metastasis better. However, if we see the survival prognosis, that seems to be better predicted by the 7th edition. So we still like probably some further modification in the next edition will take care of those, but as of now, we need to follow one of the staging system. So what it means for us that whenever we see an eyelid malignancy, we must know to mention the size of the tumor, note it down in our documents, see whether there is involvement of the lid margin, see if there is an involvement of the tarsus, conjunctiva, and if there is any involvement of the contiguous structures like orbit, bones, PNS, as well as look for any distance metastasis and lymph node involvement. Now, what is the management goal of any eyelid malignancy, especially SGC? We want a complete resection of the tumor. We want tumor-free margins while resecting. We want no local recurrence, and we want no metastasis for the patient. Now, in a tumor like this, which seems to be pretty well localized, excising it with like 3 to 4 millimeter of margin and sending the margin separately to look for any involvement of the margin, and then closing the defect is a sufficient management. But what about this kind of tumors, where the tumor seems to be involving full thickness of the eyelid, and we see a little bit of inflammation of the surrounding conjunctiva also. So here we can never be sure if we have taken a clear margin, and we sometimes might not be very sure which part actually we take it as a clear margin. So here comes the role of intraoperative frozen section. Now this has been an issue where the protocol is again not standards. Like where there is a facility available, frozen section margin clearance is followed intraop, where it is not available, or sometimes like there has been no report as such comparing the two, and what is the concordance of the frozen and the permanent section has been a matter of debate. We have a couple of publications now which have come up recently trying to answer these questions, and they have found that the sensitivity, specificity, and the accuracy of intraoperative frozen as compared to the permanent section seems to be quite good. And this study includes all the tumors. However, if you break it down according to the type of tumor, what we see that though for basal cell carcinoma, it seems to be 100% for sensitivity and specificity. But if you go down to sebaceous gland carcinoma, the specificity is 100%. However, the sensitivity is somewhere about 83%. So what it means for us is that frozen intra-op, especially for SGC, there is a possibility you might land up with a false negative. 1 in 5 patients, there can be a false negative. Means that frozen might tell you that the margins are clear, you'll end up closing the defect, but on permanent, it might turn out to be an involved margin. So what it means for us is that when we reconstruct this lesion, probably small tumors, we can go by the frozen section, but if a major decision should not be based on frozen, we should wait for the permanent and then take a call. The reason why it can happen could be various, because of the pagetoid involvement, because of the skip lesion, which this study from the Shields group tells us that sebaceous gland carcinoma can actually be multifocal involvement of the tarsus. There can be skip areas. So even if your margin is kind of negative in one, you still can have residual tumor in the other areas of the tarsus. And in fact, the recommended complete tarsectomy, excision of the whole of the posterior lamina, even for smaller lesions. Another challenging aspect of the sebaceous gland carcinoma is this kind of presentation. We all are much more aware of it now, the pagetoid type of SGC, what we call that, where there is no definite mass as such, but a diffuse involvement of the conjunctiva, and many of these patients present like a persistent unilateral blepharoconjunctivitis. Conventionally, what is done to diagnose this lesion is a map biopsy, which is small biopsy from the conjunctiva. 18 sites is conventionally what is done. However, again, whether map biopsy is required for all patients has been an area of debate, because processing these small biopsies are not really easy for the pathologist. So it involves more cost, more expenses, and there are reports where there can be non-diagnostic map biopsy because of the crush artifacts, because of the processing. And also, if you try to see literature on what is the correlation with the clinical suspicion. Clinically, if you find an area which is hyperemic, which is inflamed, the map biopsy might show those areas to be positive. But however, if clinically those areas does not seem to be involved, map biopsy, whether it's positive for those areas or not, has been a matter of controversy. The studies do say that it sometimes is not concordant, like means that clinically, what your clinical impression says and what your map biopsy says might not be concordant. So whether map biopsy, the 18-site biopsy is routinely required, the study from the MD Anderson group says that routine 18-site biopsy might not be required in all patients. It might not help you in management. However, a localized biopsy, if you're clinically suspicious of a particular area, can be done. So what does it mean for us? Smaller lesion like this, where the rest of the conjunctiva seems absolutely healthy, the first patient, we can just manage with a simple excision. However, this kind of lesion, the second patient, where there is a diffuse involvement, map biopsy is possibly recommended. So selected patients, yes, we need to do a map biopsy, but for all patients, probably it's not mandatory. This lesion probably needs a localized map biopsy of the area which is involved. Another area which is, there has been a lot of advances, is the locally advanced sebaceous gland carcinoma. Now, this tumor has patient has a tumor going right till the orbital apex. Even if you do an exenteration, probably there will still be some residual tumor. So what can be done for this patient is neoadjuvant chemotherapy, which is more and more used these days for the locally aggressive SGC, and the response has been very good for this patient. It causes kind of, shrinks the tumor, reduces the size, where a less extensive surgery can be done for these patients. We have a couple of reports now which have come up where exenteration or even mutilating surgeries can be avoided for this patient by the use of neoadjuvant chemotherapy. So in locally aggressive tumors, locally extensive tumors, we can try to debulk the tumor by initially giving chemo to this patient. 5-FU and cisplatin is the drug which is used commonly, and then probably even if you have to do an exenteration, there is a higher possibility of getting a clear margin, and the surgery will become less mutilating. A lot of study is going on the prognostic markers and targets for future therapy, targeted therapy for sebaceous gland carcinoma. There has been studies reported which say that high expression of cancer stem cell markers probably indicate a more aggressive tumors and correlate more with the metastasis. So we will see in the future, probably if this actually holds true, then this can be a target for some localized specific treatment which can reduce the aggressiveness of these tumors. A couple of drugs are already in the practice. Moving on to the BCC, again, this is how we commonly see them. What's important is to recognize this pattern, the sclerosing variant of BCC, which again presents like a lot of cicatricial changes, like an ectropion in this patient, with no localized mass. And what is available now for very extensive BCC is vismodegib, which is a targeted treatment which inhibits the Hedgehog signal pathway, which is involved in the proliferation of the cells. And tumors like this, where resection is not possible, can now be managed with the use of vismodegib. It is available in India also, however, the cost is the factor which prevents it from using it in many patients. If you see a BCC, then in selected patient, we must rule out basal cell nevus syndrome, especially in young patients with BCC, where there are multiple BCCs. A Golin-Gott syndrome or the basal cell nevus syndrome needs to be ruled out. There are criteria to diagnose it. The last bit is the targeted therapy for squamous cell carcinoma, the epidermal growth factor receptors, the inhibitors for those is now commercially available for use in the squamous cell carcinoma, and has showed good response in selected patients. So probably in future, this will also become a treatment modality for most of our tumors. So to conclude, staging, good documentation, trying to stage the tumor is very important in these patients. And whenever margin clearance and my biopsy, we need to understand where it is indicated and choose it accordingly. And newer prognostic markers as well as targeted therapy are probably going to come up in the future to help us better manage these patients. Thank you.
Thank you so much, Dr. Seema Das, and congratulations on completing it in time. We are running short on time, so we'll just quickly go on to the next speaker, who is Dr. Maya Hada, and she would be talking about lacrimal gland tumors, what's new. And I would request everyone to stick to time, otherwise we'll just run out of time.
So I'll be talking on the lacrimal gland tumors, what is new. So what we know already is the 50-50 rule. That was in a study in 1956 that 50% of the lacrimal gland tumors are epithelial and 50% are non-epithelial. But recently the data has suggested that non-epithelial are like more than 3/4. And predominantly these are inflammatory. And these are the studies of pathology, and we don't take biopsy in all inflammatory, so actually the number are even more. So the inflammatory commonly include the infectious etiologies, and we must rule out them first, and this was the case of a bacterial dacroadenitis. You must see whether it's bilateral or unilateral. Bilateral cases are mostly viral, and the orbital lobe is more frequently involved in mumps and tubercular etiologies. So the chronic bacterial dacroadenitis, they have some slow and indolent course, and most of them may be associated with some systemic diseases like Sjogren, sclerosing inflammations, and autoimmune diseases. So it's important to do the immunological workup, and our case was found to be positive for anti-SSA and anti-SSB antibodies and responded well to hydroxychloroquine and oral steroid. But this may not be there with all cases of dacroadenitis, and there are cases where you get recurrence after stopping steroids. So these are the idiopathic dacroadenitis, formerly called as pseudotumors. So what is the role of biopsy in such cases? Previously, they tend to be called as pseudotumor. Now they are turning up into the specific inflammation with inclination towards biopsy. And there are studies which are suggesting that the biopsy is not only therapeutic, not only diagnostic, but also have a curative component in it. If you remove the orbital lobe of the lacrimal gland in such cases, it happens to show 80% of the cure rate in such cases. Lymphoproliferative lesions are more common in elderly age group. This was a 78-year-old female, and whenever you see a rubbery mass which is more homogeneous and which is molding around the globe or the orbit, you must suspect lymphomas in such cases. And what should be your first step in these cases? We should go ahead with the biopsy. FNSC has no role because you need to characterize the lesion. Management varies accordingly. And the standard treatment for the lymphoma used to be the EBRT, the external beam radiotherapy in 30 to 40 gray. But nowadays the studies are showing that ultra low dose radiotherapy just in the dose of 4 gray is sufficient enough, and it's very effective for the local control. Also, we have immunotherapy with anti-CD20 antibody, that is the rituximab, for low-grade B-cell follicular lymphomas. Coming to the epithelial tumors, the most common we see is the benign mixed tumor, that is a pleomorphic adenoma. And characteristically, you will see on CT scan, they have these well-encapsulated masses causing bony remodeling without any erosion. So management, previously we used to see that lateral orbitotomy was a standard of care, but now we can see we can remove these lesions without cutting the bony flap. So it can be done without cutting the bone. This is a video. I'll just go through important steps. You must always remove the tumor with the periosteum and with its capsule. You can use cryo, or it can be removed without cryo as well. And it's important not to take biopsy. This was the earlier teaching. But these studies, they are saying that if you have a diagnostic confusion, careful biopsy prior to excision does not increases the chances of recurrence. So there are many things which are changing now. But recurrence will occur if you do incomplete excision, and that happens in 30% of the cases. And 10% of these may even undergo malignant transformation. So it's important to remove the tumor in toto with its capsule. So this was one case which presented after 7 years of orbitotomy, and there was a recurrence with bony erosion, and then we have to give post-op adjuvant radiotherapy in this case. This was an entity described by RP Center study, cystic component or cystic degeneration in cases of pleomorphic adenoma. They may rupture, they may cause recurrence, so one should have careful excision of these tumors. There may be other tumors which may mimic clinical presentation of pleomorphic adenoma. This was a lady presented with lacrimal gland mass, and we could see some lytic lesion in the scalp, and this turned out to be a plasmacytoma. If you have a relatively young patient with the lacrimal gland mass and complaining of pain as well, you must suspect adenoid cystic carcinoma. Pain is very characteristic of adenoid cystic carcinoma, and on imaging you will see that these are more elongated masses, and they will associated with bony erosions, and these are very aggressive and fast growing. There has been a wedge sign which is described for these adenoid cystic carcinoma. If you see a triangular piece of mass extending up to the orbital apex, then you must suspect fast growing lymphomas or adenoid cystic carcinomas. So as per the management, the traditional surgical management was excision followed by radiotherapy. But what is new, there is an inclination towards globe-sparing surgery. This was an article by Beta Smiley, where they have given eye-sparing approach with surgery followed by adjuvant radiotherapy, and it could have a reasonable local control. Neoadjuvant intraarterial cytodeductive chemotherapy has also been tried, and neoadjuvant chemotherapy does very good chemo reduction, and followed by that you can do surgery, and then can give adjuvant radiotherapy or chemoradiotherapy. This is an unpublished data from RP Center, where neoadjuvant intravenous chemotherapy was used, followed by tumor excision, followed by radiotherapy. So this study by Ahmed et al. Concluded that for the adenoid cystic carcinoma less than T3, that means the tumor has not yet invaded the periosteum, you can go for eye-sparing surgery, and there is no difference between the excision and eye-sparing surgery results in these cases. So this is one case of adenoid cystic carcinoma that was removed with the eye-sparing surgery, and you can see how soft and triangular they look. You should always look for any bony erosion intraoperatively, and pathological features that predict poor prognosis is the perineural invasion. There are basiloid variants which is also associated with the poor prognosis. The future is targeted therapy, and there are some apoptotic markers which have been identified, and the therapies targeting these genes may be effective treatment for the lacrimal gland carcinomas. So the key points in my presentation is debulking of the lacrimal gland orbital lobe in cases of idiopathic recurrent dacryoadenitis does have a curative role, and it does not lead to increased chances of dry eye in these cases. Careful biopsy prior to excision, it does not lead to increase in the chance of recurrence when the diagnosis is not certain, but it should be always followed by the complete excision, including the biopsy tract. The low-dose RT is the new modality in treatment of low-grade ocular adnexal B-cell lymphoma, and the 4-gray is the dose which is used in 2 fractions. Eye-sparing surgery for adenoid cystic carcinoma is leaving minimal or no tumor residual, followed by adjuvant RT or chemoradiotherapy. It provides good outcomes. And the development of targeted drugs based on the molecular biology, it may offer palliation in the patients who are having metastatic or unresectable tumor. So to conclude, the knowledge of characteristic features of different lacrimal gland tumor, it's imperative to differentiate them with diagnostic accuracy for proper management and better prognosis. Thank you very much.
Thank you, Dr. Maya, for that wonderful coverage of the advancement in lacrimal gland tumors. And by intraoperative biopsy, I think when you have pleomorphic adenoma, then you go ahead and excise it in the same sitting. Yes, okay. Thank you so much. And so now we have our next speaker, Professor Seema Kashyap. She is an ocular pathologist at RP Center, and Professor Seema Kashyap is going to present prognostication from a pathologist's desk.
Today I shall be talking about prognostic histopath high-risk features in intraocular tumors as well as a few eyelid malignancies. To start with retinoblastoma, on light microscopy we first see the differentiation of the tumor, which is very important. When you see rosettes, flexnum intestina rosettes, or homerite rosettes, or this one is fluorettes, these are well-differentiated retinoblastomas which have a better prognosis as compared to the poorly differentiated retinoblastomas which have no rosettes or fewer rosettes. Now, there are numerous histopath high-risk features which should be taken into account for further management of the patient, like massive choroidal infiltration, retrolamellar and optic nerve cut end invasion. Now these are the pictures of retrolamellar invasion. As you can see, this is the prelamellar area, and once the tumor grows in the retrolamellar region, this is a histopath high-risk feature. And this is the cut end of the optic nerve, which is involved by tumor. So this is a histopath high-risk feature which should be taken into account. Next is the massive choroidal invasion. As the International Retinoblastoma Staging Working Group definition, more than 3 millimeters thickness of choroid when involved, it is known as massive choroidal invasion, and this is important histopath high-risk feature. Iris, this is the iris involvement by retinoblastoma. This is the ciliary body involvement, anterior chamber which is involved, and trabecular meshwork. These are all histopath high-risk features, along with scleral invasion and extrascleral invasion. Once these high-risk features are present in any case, they have a greater risk of recurrence and distant metastasis. So it's important to recognize these histopath high-risk features. Now the AJCC 8th edition has added H category, or the heritable trait, in the 8th edition, and which has now become the gold standard to define the extent of retinoblastoma. This is the first evidence-based system for predicting overall prognosis of both eyes in patients of retinoblastoma. Now we have an AJCC 8th edition pathological classification. This is the H category which has been added in the clinical staging, where RB1 gene mutation has been taken into account. The H1 has bilateral, trilateral retinoblastoma, or any evidence of RB1 gene mutation. Now this is the 8th edition TNM staging system pathological classification, which we always put down in our reports. This is step ahead of what was there in 7th edition. 7th edition did not include the iris invasion, the trabecular meshwork, Schlemm's canal, as well as the involvement of sclera, meningeal spaces. So this is a better prognosis can be identified by this 8th edition. A little bit about immunotherapy. This could be the future of to treat retinoblastomas. Their immunotherapy could be used along with chemotherapy to reduce the side effects of chemotherapy, or as such alone, in these patients of retinoblastoma. Now, in our department also, we had conducted a study on 262 prospective cases of both primary and chemo-reduced retinoblastomas. And what we found was that overall survival was reduced in all cases where PD-L1 was expressed in primary retinoblastoma and PD-1 expressing chemo-reduced retinoblastoma. So these could be used as poor prognostic markers and further therapeutic targets in the near future. These are the expressions, the strong expression of PD-1 in the tumor as well as in the stroma. Similarly, the PD-L1 expression in the tumor and the stroma, and CTLA-4. This work was presented in ESMO Immuno-Oncology Conference in October 2019 in Geneva, and it was awarded the Best Poster Award. Now going on to melanoma, this is the cut section of eyeball which is showing this uveal melanoma with complete retinal detachment. Histopathologically, we have the spindle cell type, epithelioid, and the mixed cell type. The epithelioid cell type, where you have these prominent nucleoli, numerous mitotic figures, have a worse prognosis as compared this to the spindle cell type. So it's important to recognize the cell type in melanomas. Now, recently, the tumor-infiltrating lymphocytes, tumor-infiltrating macrophages, increased pigmentation in the tumor, increased microvascular density have also been recognized as poor prognostic factors, along with scleral invasion, necrotic melanomas, and optic nerve infiltration. So these are the high-risk clinical parameters where the high-risk factors are analyzed, and these are the histopath parameters where epithelioid cell type, which I just showed you, scleral invasion, tumor-infiltrating lymphocytes, macrophages are included. Now, those tumors which have high-risk factors are metastasis. So these need to be recognized. Cytogenetic markers have also been used to determine prognosis, like aberrations in chromosome 1, 3, 6, 8. But most important is chromosome 3 loss. It is also known as monosomy 3, where there is complete loss of one allele of chromosome 3. As you can see in this chromosomal analysis, there's only one allele, and this is FISH. By FISH on fresh tumor tissue as well as formalin-fixed paraffin sections, it can be done where this is a disomy. Both alleles are present in this particular cell also, both alleles are present, but in this particular cell there's only one allele. So this is monosomy 3, an important prognostic parameter. So based on the gene expression profiling, this is transcriptomic analysis. Gene expression profiling, it has been graded into class 1 and class 2 tumors. Class 2 tumors are the ones which are high grade, epithelioid cell type. They have a high risk of metastasis. Monosomy 3 is present in this particular class 2 tumors. So there's a need to recognize these patients and keep them on regular follow-up, since the 5-year risk of metastasis in these cases is about 70 to 80%, and we adjuvant therapy may be offered to these patients in order to reduce the risk of metastasis, which is almost always fatal. BAP1 is another important prognostic parameter. There are many studies which have shown that loss of BAP1 expression is associated with increased metastatic risk.
Ma'am, I would request you to wind up so that Lomi can also give his last talk. I'm really sorry, but I think really sorry. I think just took more time.
BAP1 and monosomy 3 are important prognostic parameters. In a study which was conducted, we also found that loss of BAP1 was an independent predictor of metastatic disease. So I think since we don't have enough time, I shall skip the eyelid malignancies. That's all, yeah. So to conclude, the histopath high-risk features are very important to be recognized in any of these tumors, whether it is intraocular tumor or eyelid tumors or orbital tumors. Since they predict prognosis and these patients have to be treated accordingly. Thank you.
We have the last speaker with us now, Dr. Lomi.
Okay, I will quickly give a very fast appraisal of what.
You have 1 minute, Dr. Lomi. So
what all you can
speak.
do it. Yeah. Next slide isn't working. Yeah. So choroidal melanoma, how can you diagnose it? Basically, the patient comes with incidentally. You can check during the routine ophthalmoscopy, the fundus examination, and also the patient comes with blurred visual acuity, the paracentral scotoma, or progressive loss of the vision, and sometimes comes with the floaters. So in next slides we'll go quickly about the diagnosis and the management. So in clinical features, when we see a dome-shaped mass, choroidal mass, which may be pigmented, non-pigmented, when you see a mushroom shape, that means that it has gone through breaks through the Brooks membrane and then come internally. And then it may be associated with retinal detachment, exudative retinal detachment. So one of the important diagnosis here is you do ultrasound, this A and B scan ultrasound. So here you see a very characteristic features with mild to moderate amplitude spikes because of homogeneity of the mass. And then you have got a very steep angle capacity, the steep decay of the internal reflectivity, and you have got a choroidal excavation and acoustic shutdown. So this is a very typical sign of a case of choroidal melanoma. And others are fundus fluorescence angiography, where you can find sometimes differential diagnosis difficulty with choroidal hemangioma and all. So here we have a early hypofluorescence and a late hyperfluorescence. Another is the OCT. You can see a serious retinal detachment with a debris on the back of retina with normal thickness retina. And sometimes MRI is another important imaging tool, like for looking for extra ocular growth and also the optic nerve involvement, where you find a hypo-intense in T2 weighted images and then hyper-intense in T1 weighted images. PET-CT scan is another important tool to rule out any distant metastasis, where you find the liver is most common area where you can find metastasis. So it's very important to rule out any systemic metastasis before you carry on with your management. Sometimes you find a very atypical presentation where you need to do a final aspiration cytology, where you have to take into account the risks versus the potential benefit of this FNSC, like in case of diffuse choroidal melanoma, or in very young children where you find a choroidal mass like this, or very anteriorly located mass, and sometimes a case of amylolytic choroidal lesion. So I'll skip this video. We can do it FNSC, and then with a 2-port pass planner, and then you can find it cytology also here. So what all can be done when you diagnose a case of choroidal melanoma? So there are various determined factors, like depend upon size, location, and extent of tumors, the visual status of the affected eyes and the fellow, the age and general condition of patient, and most important, the patient's consent, and then the motivation to retain the globes. So there's various treatment strategies, like for small, medium, and large. Small melanoma we can observe, or we can do the transplant thermotherapy, and then medium we can randomize into plaque brachytherapy or combined plaque brachytherapy with TDT, or we can do a gamma knife therapy. And for large, you can either go for enucleation, or you can do this external beam radiotherapy like a gamma knife. So for small, we usually consider for the apical thickness of less than 3 millimeter. You can go for transpapillary thermotherapy. It's an infrared radiation that gives a thermal effect and cause apoptosis to cells. The plaque brachytherapy is one of the most common these modalities which we usually use now. Either you can use ruthenium-106 or the iodine-125. For ruthenium-106, the apical thickness is less than 5 millimeter, and then for iodine, it should be less than 10 millimeter. Where you can identify the location, you can place a plaque with a radiation dose around 70 to 100 gray, and the treatment duration will be around 5 to 8 days. So this is the result of one case with after 9 months post-plaque brachytherapy.
I think Lomi will have to conclude. Yeah.
So another indication, gamma knife therapy, and then this is how you do the gamma knife therapy. And for last, irrespective of whatever treatment or modalities you choose, patient need a careful observation for years, and initially 3 monthly you can do, and if there is no change, then 6 monthly, or if growth or any defect, you can consider for any further management, and yearly PET-CT scan whole body may be helpful for early detection of distant metastasis. Thank you.
Thank you, and thank you for your patient hearing, and my apologies to Dr. Neeraj and his team for extending on to their time. Thank you so much. Thank you.